Hello everyone, welcome to my YouTube channel. Today I decided to make a YouTube channel to go over some of the important and high yield topics regarding different specialties. This is mostly directed towards medical students. So today's topic, we're going to be talking about heart murmurs, and maybe we'll go over congenital heart defects as well. So we'll first start off by going through the systolic and diastolic murmurs. What you need to know about these heart murmurs, that there's only two diastolic murmurs, which is aortic regurgitation with mitral stenosis. All of the rest are systolic. Let's go through the systolic. Is aortic stenosis, mitral regurgitation or tricuspid regurgitation, mitral valve prolapse, and VSD, ventricular septal defect. So first let's start off with aortic stenosis. So first, it's regarded as an early systolic ejection murmur. This is very important. It's mostly heard at the right second intercostal space and the second intercostal space, and it's usually regarded as a crescendo decrescendo murmur. And what is the clinical tie-in with aortic stenosis? Is this one very important mnemonic that you need to know? It's called SAD. So syncope with angina and dyspnea. So in the question, if they tell you that a 50-year-old male presented with fainting, instantly you should the first differential in your mind should be aortic stenosis, especially syncope due to exercise as well. So what are the two main causes of aortic stenosis? Is most commonly is age-related calcification of the aortic valve. What is the second most common cause of aortic stenosis? This is bicuspid valve it's just bicuspid valve. What is this seen in? Mostly in Turner syndrome. Turner syndrome is also associated with a coarctation of aorta. So if they give you a patient that's even in pediatric or adolescent age with syncope, angina, or dyspnea, angina is the chest pain due to mostly due to exertion, you would also be thinking about Turner syndrome. That's very important. So what are the physiologic complications of aortic stenosis? Is that we would eventually have hypertension and left ventricular hypertrophy because the aortic valve is closed shut, right? So the left side of the heart needs to do more work. It needs to work overtime in order to push blood out into the systemic circulation. So that's very important tie-ins that you need to know from left ventricular hypertrophy. If you shoot farther than that, you'll find that you'll get right ventricular hypertrophy. What is the most common cause of right ventricular hypertrophy? Is left ventricular hypertrophy. That's very important. Right ventricular hypertrophy is also called cor pulmonale when you have right-sided heart failure. Alright, moving on. We'll move on to the next murmur, which is aortic regurgitation. Aortic regurgitation, what you need to know is very simple. It's early diastolic decrescendo murmur. Oh, and I also forgot to say that the murmur of aortic stenosis usually radiates upwards towards the carotid arteries on the right side. Okay. What else did I miss? Oh, also in aortic stenosis, there's a phenomenon called pulsus parvus et tardus. It's not very high yield. Is when you have slow rising pulses. Usually this can be seen in the carotid arteries. There you go. Now we'll go back to our topic, which was aortic regurgitation. It's an early diastolic decrescendo murmur. What's very important is that it can cause wide pulse pressures. Widened pulse pressure. What is it? Is when the number of the diastolic is very far away from the number of the systolic. For example, if we have a systolic of 130 and then the diastolic would be, for example, 50. This is what we call a widened pulse pressure. It's very high yield. You usually see it in a lot of exam questions as well. And in extreme cases, you will have something similar to aortic stenosis with pulsus parvus et tardus, but it's called head bobbing. This usually manifests in severe or chronic aortic regurgitation, where you notice that if you ask the patient to stay still, you'll notice that their head bobs upwards and downwards, as well as the earlobe as well. That's very important. All right. So, moving on. What are the causes of aortic regurgitation? There's another important mnemonic. It's called BEAR, which is bicuspid aortic valve, endocarditis. As we know, endocarditis causes regurgitation. It could be a late sequelae of rheumatic fever. What's important about rheumatic fever is that it causes early regurgitation and late stenosis. That's very important for you to know. Remember, rheumatic fever is mostly seen in the pediatric age population with a history of group A streptococcal infection, such as strep throat. Now, what's also important is the Jones criteria, which was joint issues, polyarthritis, O, which is in the shape of a heart, causes pancarditis, so which is the three: pericarditis, myocarditis, and endocarditis. N is nodules, so erythema nodosum. The E stands for erythema marginatum, and S is Sydenham chorea. Sydenham chorea is dyskinesia, where you have involuntary movements of the limbs. Okay, now let's go back to our topic. So we went to bicuspid aortic valve, we have endocarditis, we have late sequela of rheumatic fever, and we have aortic root dilation. What's very important about aortic root dilation? What does it tell us? It tells us that there could be possible aortic dissection. Aortic dissection, remember, is split into type A and B, which is the Stanford classification. When you have aortic root dissection, the aortic root, which connects to the left side of the heart, becomes dilated, which then causes the aortic valve to become widened, causing which causes aortic regurgitation. Okay. Also, aortic regurgitation can lead to left-sided heart failure as well. Left-sided heart failure. Why? Because, again, similar concept to aortic stenosis is when you have aortic regurgitation, the left side of the heart becomes overworked because you have insufficiency of the aortic valve. leading to left ventricular hypertension, leading to left-sided heart failure. Sorry. Okay, now that's it for aortic regurgitation. Now we'll move on to the mitral pathologies. Let's go on to mitral stenosis. Mitral stenosis is the mid to late diastolic murmur with a characteristic opening snap or click. Now, what does this contrast you into mitral valve prolapse, which we'll talk about in a bit? Okay, what's the most common cause of mitral stenosis? Almost always caused by rheumatic fever. It's very, very important to know that 99.9% of mitral stenosis is caused by rheumatic fever. Now, mitral stenosis has a very important physiologic tie-in, where when you have stenosis of the mitral valve, right above is the left atrium, correct? What becomes the left atrial pressure becomes very increased, which causes the dilation of the left atrium itself, leading to stretching of the bundles of the nerve bundles inside the left atrium. So the sinoatrial node becomes less active, which causes which can actually cause atrial fibrillation. And what happens when mitral stenosis? There's an increase of blood pressure within the left atrium, correct? So this increase of pressure in the left atrium can actually go backwards towards the pulmonary circulation, leading to pulmonary congestion, which manifests as pulmonary edema. Correct? Okay, now what else do I have to say? As I said, it's described as a rumbling diastolic murmur with an opening snap. It can cause a right-sided S4 if the pressure backs up all the way into the right heart. An S4 is a diastolic sound heard either in the left ventricle or right ventricle when there's a diastolic stiffening due to high afterload. 99.9% of mitral stenosis are due to a history of rheumatic heart disease. Sometimes the vignette or the question can give you a rumbling diastolic murmur without an opening snap, but it's still mitral stenosis. Another high-yield presentation is in a pregnant woman, especially with new onset dyspnea in the second trimester with a diastolic murmur, because as you know, during the second trimester there's a plasma volume increase, which causes subclinical MS to become symptomatic due to the high increased blood volume, causes stress on the mitral valve, leading to mitral stenosis. Okay. That specific 0.1% of mitral stenosis that is not due to rheumatic fever can be due to non-bacterial thrombotic endocarditis, which is seen due to hypercoagulable state in the setting of malignancy. So what is the treatment of mitral stenosis? Well, all you need to know is that the valvuloplasty. You need to do a valvuloplasty. Most of these murmurs are resolved from surgery. That's very important. Now, moving on to mitral regurgitation. All regurgitant murmurs are described as holosystolic or pansystolic, depending on the question. So, mitral regurgitation is still a systolic murmur. What's a very important tie-in, but is not always given in question, is that it radiates radiation to the axilla. But some questions don't give this tie-in. Okay. Now, the highest yield cause of mitral regurgitation is post-MI papillary muscle rupture. The vignette will actually give you a question of an MI patient 1 to 3 days after an MI, or 3 to 14 days after an MI. You'll notice that he has a new onset murmur. Most likely cause of that in the setting of an MI is a papillary muscle rupture. So the papillary muscles are actually they actually hold the mitral valve close. So when they rupture, the valve becomes loose, causing a regurgitation of blood. Now, it's also seen acutely in rheumatic heart disease. And mitral regurgitation, very important, can cause pulmonary congestion leading to pulmonary edema, and it can cause jugular venous distension when the blood backs up all the way to the right heart. It's asked actually multiple times in these questions. Now, what's next? Usually it doesn't require much management, but again, if you do management, it would be surgical. If the patient has symptoms of heart failure or ischemia, we do a preoperative stress test to determine MI risk. Mitral valve is replaced if a patient develops severe pulmonary symptoms such as pulmonary edema. If he has these systemic symptoms such as pulmonary edema or JVD or right-sided heart failure, you have to do surgical correction of this defect. Okay, which is next? Mitral valve prolapse. Now, there's a very important tie to mitral valve prolapse. It's described as a late crescendo murmur with, which is extremely important, mid-systolic click. This mid-systolic click is very important. Don't confuse it with opening snap or click of mitral stenosis, okay? So now let's go into the causes of mitral valve prolapse, most commonly due to Marfan syndrome, which I believe is a defect of collagen, and Ehlers-Danlos syndrome. Very important. What else do I have to say about mitral valve prolapse is that the main answer in the question, if they ask what is the etiology or what is the cause of mitral valve prolapse, apart from Marfan syndrome or Ehlers-Danlos syndrome, is actually myxomatous degeneration, which is also connective tissue degeneration causing mitral valve prolapse in Marfan's and Ehlers-Danlos syndrome. And it's almost always asymptomatic, and you usually don't treat mitral valve prolapse. It's very important. Now, mitral valve prolapse has a tie-in. When it does become symptomatic, it presents as a left-sided fleeting chest pain. Now, I said left-sided, not full chest pain. Fleeting chest pain that is episodic in nature, and it goes away usually after 10 to 20 minutes or even a couple minutes. Okay, now what can we contrast this with? We can contrast this with panic disorder or panic attack. Okay, panic attack is usually when a person has an impending sense of doom. They have chest pain, hyperventilation, all of these symptoms, but it's very episodic and it usually goes away within the 1 hour. It peaks at 10 to 20 minutes. That's very important to know. Mitral valve prolapse, it's important for you to know that it does not progress to mitral regurgitation. Okay, and what is after that? Ventricular septal defect. This is very, very important, especially in the pediatric population. It is a holosystolic murmur, But what contrasts it from other regurgitant murmurs is that it's harsh. It's a very harsh sounding murmur at the left lower sternal border, or it could be at the apex. Now what you need to know about tricuspid regurgitation is that tricuspid regurg almost always causes pulmonary symptoms, pulmonary congestion, and JVD also. Tricuspid regurgitation, think of this in IV drug users. That's important too. And it's loudest at the left lower sternal border. Okay, I think that's about it for today. Have I missed anything? I do not think so. Oh, I'll just mention one more, which is a PDA, patent ductus arteriosus. What is the most common cause of patent ductus arteriosus? Is congenital, rubella syndrome. Now what does congenital rubella syndrome present with? It presents with cataracts, deafness, and PDA. Now what is a PDA? It's a murmur that's loudest at left infraclavicular region. That's very important for you to know. It's loudest at the left infraclavicular region. Now, what else should we know? For example, in the vignette, it will tell you that the mother had a history of a rash and arthritis. This basically tells you that the mother had symptoms of rubella during her pregnancy. It crosses the placenta, can also cause rubella in the child. So when the baby is born, it will mention cataracts, as I mentioned here, cataracts, deafness, and the murmur loudest at the left infraclavicular region. Now what's important is that PDA usually closes on its own, but when it doesn't close on its own, that's pathologic. What do we give to close the PDA? Prostaglandin E1 is used to keep a PDA open. NSAIDs actually close the PDA, such as indomethacin. And it's cyanotic. Okay, that's all for today. Thank you.